Good evening and welcome to Doctors on Call. I'm Dr. Mary Owen, a family medicine physician for the Fond du Lac Band of Lake Superior, Chippewa, and a faculty member at the University of Minnesota Medical School, Duluth. I'm your host for our last program of the season, and tonight we'll talk about eye problems. The success of this program depends on our viewers, so please call in with your questions and we'll do our best to answer them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Charlie Ahrens, an ophthalmologist with St. Luke's Eye Care at Miller Creek Medical Clinic in Hermantown, Dr. Matthew Cossack, an ophthalmologist with Essentia Health, and Dr. Lisa Graham, an ophthalmologist with Ralph Eye Care Specialists in Hermantown. Our medical students answering phones tonight are Paige Carlson of Wadena, Minnesota, Josie Nisler from Breezy Point, Minnesota, and Linda Liskowitz of Duluth, Minnesota. And now on to tonight's program on eye problems. Thanks for being here. And people are so excited about our show tonight, they've already sent a question in. They emailed one. So let's start with you, Dr. Graham. Caller from Duluth has dry eyes, uses OcuSoft Plus wipes, Systane preservative-free drops, and occasionally Zaditor. They still wake with crusty lids and clear mucus discharge. Their eyes itch and look bloodshot. What does this mean and how should they treat it?
Wow, sounds kind of miserable, but that's kind of a classic history for maybe a combination of dry eyes and blepharitis. And they're already doing a good regimen for blepharitis, but probably need more help. So they should probably go see their eye doctor. Might need a short course of antibiotic on the eyelids. Might need to step up the dry eye therapy with either a prescription eye drop or maybe a small procedure like blocking some of the tear drainage with plugs. Okay. So there's a lot of options, and they need a good eye exam and to determine the course.
Excellent, thank you. Yeah. Dr. Cossack, what do you most commonly see referred to you from family medicine physicians or from primary care?
That's a great question. Typically, you see patients sent for cataracts, which is one of the most common eye problems that patients experience, especially as they age. With age, your lens becomes cloudy, and the only effective treatment is surgical at this point. And so for that reason, many patients, when their vision is cloudy, are eager to have their cataracts done and can have a lot of improvement. The other top reasons would be diabetic eye exams. It's important to be seen every year for diabetic eye exams when patients have diabetes, as it's a condition that can lead to blindness if sugars are uncontrolled. And dry eye is certainly very common, and there's a wide variety of other problems as well that we may discuss tonight, but those are some of the biggest.
Great, thank you. Dr. Ahrens, patients often ask me or seem confused to me as when they should tell me they have something going on with their eye. They have lots of different symptoms. They might have floaters, but they don't know if they have too many floaters, or they might have some red eye. They're just not sure what constitutes something that they really need to see their doctor about.
Okay. That's a pretty broad question. And, you know, number one, I kind of tell patients that if you're worried about it, if it's something that you've been thinking about a lot, you're worried about it, it's always a good idea to come in and see us. Particularly, I always tell patients the big three: pain, redness, loss of vision. If that's particularly new or it's impeding your daily life, those are always good reasons to come in. You know, we, like both of the other panelists have said, we see a large gamut of things, and you know, just if they're talking to you and there's some confusion, sometimes it's nice just to be able to see us, and then we say, okay, this is what it is, and this is where we can go from here. So sometimes that gives patients ease of mind too. So I have a really low threshold that we'll see patients if they're nervous about something, even if I get to tell them, hey, everything is fine, everything's good. I'd rather be able to tell them that than have them wait too long on something, come in later, and then we have a real issue on our hands.
Okay. Dr. Graham, we were talking earlier, and there are a couple different therapies to help restore vision besides glasses and contacts. One is LASIK, and you mentioned another one. Can you tell us more about those two and why one would want the other and or
Sure.
one over the other?
You know, there are several procedures, elective procedures to correct vision. The most common is laser corneal refractive surgery, LASIK for one, and PRK, which is photorefractive keratectomy, is the other main one. LASIK involves creating a thin layer of the cornea to lift up and then do a reshaping treatment to correct the prescription. And PRK, you kind of do that on the surface. So for some people, having that flap of tissue is sort of contraindicated. If they have really dry eyes or really thin corneas, they might not actually be appropriate to have either procedure, but so they need a good thorough eye exam to determine which one they're a candidate for.
Excellent, thank you.
Yeah.
Dr. Cossack, someone asks or states that they're going to be having cataract surgery soon and they're also being watched for glaucoma. Will the cataract surgery help their glaucoma?
That's a great question. And it's important for cataract surgeons to evaluate for glaucoma because it's very underdiagnosed. A lot of patients have it and don't realize that they have it. And before you enter an eye surgically, it's important to know the other issues going on because patients deserve a fair prognosis of what they might expect. I'd hate to do cataract surgery for a patient, have them recover and ask, well, doctor, why can't I see? And say, oh, there's another thing I didn't tell you about yet. So it's important to evaluate for glaucoma at the time of cataract surgery because it may influence how your surgery is done. So there are combination procedures that range from very simple, a minute or two, to more complex glaucoma procedures that could take 20 or 30 minutes extra that can be done at the time of cataract surgery and can treat both problems at the same time. The cataract surgery by itself, however, lowers your eye pressure, and that lowering eye pressure is the only way to treat glaucoma. So even simply having cataract surgery can be helpful for glaucoma patients.
Well, that might answer this other question. Somebody has had a second cataract surgery, but they feel like they're still looking through a screen. Suggestions on how to fix that. So sounds like glaucoma could have been one, or is there anything else they should be thinking about?
Sure. So cataract surgery tends to clear up the vision for most patients, but maybe a fourth of patients over long term develop scar tissue on the back of their lens. And a laser procedure can be used to clear that scar tissue away. That laser is very easy, 5 minutes in the clinic, there's no pain. But for patients that have had cataract surgery and have had the laser to clear any remaining scar tissue who still have blurry vision, they should see their eye doctor because they could have other undiagnosed issues. And it could be as simple as dry eye or as difficult to treat as scar tissue on the retina or other problems in the eye. It's difficult to say what it might be.
Okay. Dr. Ahrens, does excessive exposure to sun cause cataracts?
Most of the studies say that yes, exposure to UV does increase the formation of cataracts. The question is, what do we tell our patients in regards to that? I will usually tell my patients cataracts are inevitable. If you live long enough, you'll get cataracts. That's why it's the most commonly performed procedure in the U.S. So the things that you can do to help that, though, are obviously UV protection, wearing UVA, UVB protective sunglasses and things like that. You're still going to develop cataracts, but that's also going to protect your eyelids from sun exposure. It's going to protect your retina from sun exposure. So it might slow down the development of cataracts. We have studies that show that, but you're still going to get them, unfortunately, if you live long enough. And that's where the cataract surgery, like Dr. Cossack was talking about, comes in.
Okay, thank you. I think this is similar to what you already answered, Dr. Graham, but here we go. This patient is having, or this person is having troubles with gritty eyes. Their eyelashes are crusted over. They've tried warm washcloths. Any other suggestion or help?
Yes. So like that other patient mentioned, artificial tears, lubricating eye drops. Everybody's eyes are dry in Minnesota in the winter, pretty much. So over-the-counter artificial tears. Warm compresses, but you can also wash your eyelids with a over-the-counter eyelid scrub preparation, such as OcuSoft or Sterilid, or you can just simply use baby shampoo. Okay. No more tears, it's safe for the eyes, and then if that doesn't help, they probably should see their eye doctor.
Okay, thank you.
Yeah.
Go ahead, Dr. Cossack.
Can I'll add a point to that. As a patient myself, I have some of those same complaints. It's a common condition called blepharitis, and a typical cause of it is that the oil glands are too thick, the oils are too thick and they're not flowing like they need to. For thickened oils, they need to be thinned out with heat, and a lot of my patients may use a warm washcloth, but it's not enough. A good analogy is like a stick of butter. If you were to splash some warm water on, it's not going to melt the stick of butter. It will take enough minutes, enough time, good contact with the heat source, and a high enough amount of heat. So I found the most relief personally with a heated eye mask that can be microwaved, and it can be reused night after night to help loosen up those oils to help lubricate the eyes.
Great, good tip, thanks. So this is a common question that I get, Dr. Ahrens. What is the difference between an optometrist and an ophthalmologist?
So an ophthalmologist, all three of us, we went to 4 years of medical school and then 4 years of highly specialized medical and surgical training for diseases of the eye. An optometrist goes to the 4 years of college and then goes to 4 years of optometry school. And that's pretty much the difference right there.
Thank you. Dr. Graham, can you tell us, is there any new research on macular degeneration?
Boy, there's always a lot of research on macular degeneration. I think the majority of research now is in trying to discover why people get it. We know there's genetic factors, there's nutritional factors, there's probably also other systemic factors like inflammatory conditions that are involved. So it's definitely multifactorial, and there's a lot of research going on in that arena because everybody wants to prevent it because it's so common and so devastating to have serious loss of vision. A lot of research is ongoing for medications to treat it, and particularly the wet type of macular degeneration. There's two types, the dry and the wet type, and the wet type tends to have more severe and quicker loss of vision. And most of the medications are aimed at that, at treating that and halting that progression.
Dr. Ahrens, Dr. Cossack, anything to add?
When we're doing the retinal injections, part of my practice with doing the retinal injections and I think a lot of the physicians who do these types of treatments, we fight with how frequently do we need to be bringing our patients back, how frequently are we doing the injections. So a lot of the research now from that side of it, from how often we treat, is starting to come out. Do we make sure that we keep patients at least every 2 months versus every 3 months? And some of the drugs now that we're developing are trying to get to that longer duration of action. We have a new medicine out that we think lasts about 3 months. There are still some issues with it, so I personally have not been using it yet. And then there are also drug delivery mechanisms that we're looking at, meaning can we place a small rod of the medicine within the eye that will emit over a long period of time. We already have some of those with steroids, and we're trying to develop those for not only macular degeneration but also for glaucoma and things like that. So hopefully in the future there's going to be a small surgical procedure where we have a reservoir that will emit over a longer period of time to prevent patients from having to come in and see us as frequently.
That's pretty exciting.
Yeah, I think so.
The possibilities.
Yeah, very exciting.
Doctors get excited easily. All right, anything else to add to that, Dr. Cossack?
On a very similar note, a lot of patients ask about treatments with vitamins, and there have been large studies, age-related eye disease studies, that looked at this question for cataracts as well as for macular degeneration. And regarding cataracts, vitamin supplementation was not found to influence the course of cataract growth. But for macular degeneration, when it is already present, it can slow the development of it. But for patients that don't have macular degeneration, there is no benefit to these vitamins. And I've even seen studies stating that some of these vitamins may be harmful if taken when not necessary. In fact, they may increase your risk of developing macular degeneration.
Which vitamins?
The eye vitamins, like Ocuvite, they're great vitamins and they work well when you have macular degeneration. But there are many patients that may be spending some of their money unnecessarily and likely not helping themselves with these.
Excuse me. Dr. Graham, this patient has a slightly elevated copper level. Why is this relevant to her eye health?
Boy,
What is it?
There's a copper storage disease that can affect the eyes, and maybe this is what the patient's getting at, called Wilson's disease. And the copper can deposit in the cornea, and it's quite easy to see it if it's there. So it's a way to diagnose that disease. Copper supplementation is important in macular degeneration as well. So Maybe that's part of the question as well. But it's a pretty rare disease.
Okay, thank you. Dr. Ahrens, is it risky to have vitrectomy to remove floaters?
That's a really good question. So any surgery that we do there's risk. So the vitrectomy that the retina specialists are doing nowadays, just like any other surgical procedures, we're getting better and better, and the risks are less and less, but there's still a risk. So, if a patient does have symptomatic floaters, usually I'll try to watch the patients over a longer period of time, see if they get used to it. The large majority of patients with floaters do get used to the fact that they're there and don't need any surgical procedures. If it's to the point where patients can't function in their daily lives because of it, then I will recommend a vitrectomy, or at least have a visit with a retina specialist. But it's pretty rare that we need to do that. There are new lasers that are coming out, part of the studies and the new stuff that comes out that say they can help with the floaters and break up the floaters. I personally think that the jury's a little bit still out on that, but it's an exciting possibility for treatment that has less risk than the vitrectomy, although it still does have some risk.
Thank you. Dr. Cossack, how would you treat rosacea of the eyes?
Well, rosacea is a condition that can affect the eyes, and it affects the eyelids. That's the mechanism by which it affects the eyes. And it does it by causing inflammation of the eyelids. And so many of the treatments that we talked about before for dry eye would be similar treatments that could be used. Those would include teardrops, heat, and eyelid scrubs. But rosacea of the eye in particular would respond to oral medication like doxycycline can be used. This is an antibiotic, but it has anti-inflammatory properties, and that's what can be helpful in this sort of a case. There may be a limited role for steroids as well, but I'd recommend close monitoring by their physician.
All right. Dr. Ahrens, pardon me. Something in the air tonight. How do you know what eye surgery is best for you if you need seeing for both far and near? If you need help seeing for both far and near, so you're nearsighted and farsighted.
So, kind of wondering where that question goes. My assumption is that that's a refractive surgery, such as LASIK or PRK that Lisa was talking about earlier. The large majority of times that we do refractive surgery, whether it be cataract or laser refractive surgery, if we're doing it strictly as a refractive surgery like LASIK or PRK, the large majority of the times we're focusing patients for the distance. Now you could theoretically do one eye in the distance, one eye up close. We call that monovision. That works well for a lot of patients. Unfortunately, in the laser realm and laser refractive surgery, there's no perfect surgical procedure to do both of those. So most of the time, if you ask a patient, they're going to be okay wearing cheaters or over-the-counter reading glasses when they need to, because as adults, most of our life is still out in the distance. If we're talking about cataract surgery, that's a little bit different. There are some people who like having their vision being up close. If they do the majority of their work up close, they'll keep it that way. And again, when we do refractive surgery, when we do cataract surgery, we do have refractive cataract surgery with extra lenses that can do both. They can do both the distance and up close. We can correct for astigmatism, and so there are a lot of different options that we can do, and it's kind of a unique decision for each patient, and so that's hopefully what we're spending a lot of time with our cataract patients and our refractive patients to discuss, what they like to do, what their hobbies are, and that a lot of times can help hone in where we're going to focus patients.
Thanks, that was helpful. Dr. Graham, can you tell us more about iritis, what it is, and what are the treatments?
Iritis is inflammation, usually in the front of the eye. Iris is the colored part of your eye, and that's where the term iritis comes from, when that tissue is inflamed. There is a myriad of reasons people can get iritis. You can get it just from trauma to the eye. You can get it from connective tissue disease or arthritis. You can get it from some skin conditions. It can be genetically associated. Most commonly, we treat it with steroids. So usually when a patient shows up with iritis in one eye and it's the first time, we'll treat it and see how they do. If they get it over and over and over, then we start to have to do testing to try to figure out why they're getting it, either genetic testing or blood testing for various conditions.
Thank you. Dr. Cossack, this patient, or person, pardon me, is seeing floaters in their vision. Any suggestions on making them go away?
Well, floaters are an important symptom to watch out for. The floaters generally come from the vitreous jelly of the eye, which tends to liquefy and shrink with age. And then those floaters become little blur spots in your vision. When they present for the first time, you should be seen by an eye doctor because it can also present with tears and holes in your retina. So it's important to see an eye doctor for that reason, especially if there's flashing lights at the same time. There's very little good treatments for floaters, though. We already discussed surgical options not being potentially worth the risk in a lot of cases. And then laser options, which are an option but also do come with risks. So in general, I advise patients to observe them and just give them time. They tend to soften and to become less of a bother as the brain learns to filter out that information and stop telling you about it.
Dr. Ahrens, we have a dad who has an 11-year-old who just went on a scouting trip, and now they have pink eye. Does rough housing cause pink eye?
No. Feel free to roughhouse all you want. But if the question, well, pink eye can be a lot of different things. So a red, goopy eye, particularly if it starts in one eye than the other, it could either be a virus, it could be a bacteria, it could be a lot of different things. The most common thing that we see when we say pink eye is a viral conjunctivitis, which is usually caused by the common cold. So if you got a bunch of scouts hanging around and they're hanging out together and in a camp setting or something like that, whatever it may be, it's certainly reasonable that they could have gotten the common cold, or if, I have an 11-year-old scout. So, sometimes hand washing is not the best, and it's very easily transmittable. It's very contagious. And so if it is truly a viral conjunctivitis, that's probably how they got it, more likely just being in close contact with a bunch of other people who may have been sick. Roughhousing didn't do it.
Okay, thank you for that. Reassured many people out there. Dr. Graham, can you please talk on punctal plugs for eyes?
I briefly mentioned it and somebody picked up on that. So the punctum is a little opening in the inner corner of your upper and your lower eyelid, and it is the entrance to the tear drainage system. So the tears are made in the lacrimal gland in the outer corner of your eye. They travel across your eye when you blink, and they go down this drainage system into the nose and throat. So people who have very dry eyes and aren't making enough tears, we can block a portion of that tear drainage to keep their natural tears and their artificial tears in their eyes longer. And usually it's for people who have more severe dry eyes that drops alone aren't sufficient to keep them comfortable. And usually we try, I usually do a dissolving plug as a trial, and then often if they find relief from that, I'll just even cauterize one of the tear ducts.
Thank you. Dr. Cossack, and I think this will probably be our last question. My doctor says there's a white spot on the back of my retina and keeps an eye on it. What causes it?
Well, there can be many different spots in the back of the retina. The most concerning would actually be more of a brown spot, which could be like similar to a freckle on your skin, that if it were to grow or change would be concerning for a cancer. That's an important reason why you should have eye exams. White spots are a little less common. They could be seen with diabetes or high blood pressure and a variety of much less common conditions as well. But in general, any sort of spot in the back of the eye should probably be watched.
Okay, thank you so much. Is there anything else that we should be telling our patients or think that you can think of that we didn't hit on tonight, any of you, in this last minute that we have?
I think we hit a lot of the stuff, but I think your earlier point of when to come and see us, if you're nervous about things, if you have new vision changes, Like I said, I tell all my patients, come in, let us take a look at you, let us figure out what's going on, even if it's something minor, and we can tell you, hey, everything is okay. It's a lot better if you get seen first as opposed to letting something go, because things tend to be a lot harder to fix or to treat the longer we go without doing so.
Thank you. Dr. Cossack, anything to add to that? Dr. Graham?
It's important to know when to come in, and a lot of patients will get confused about their symptoms. It can be very easy to cover one eye and identify if one eye is seeing worse, especially if you're having any trouble. It can be very helpful to tell us about that.
Thanks. Dr. Graham, any last parting words of wisdom?
Routine eye exams are great. I think every kid should get an eye exam at least at one point in their young years, especially if they've already seen their primary care doctor and they didn't have proper vision at their vision screening or well child screenings. And then adults every now and then. You don't necessarily have to go every year unless you're diabetic or you have another pathologic reason that you should come every year. And then your eye doctor can tell you how frequently you should be seen.
Excellent. Thank you all. I want to thank our panelists, Dr. Charlie Ahrens, Dr. Matthew Cossack, and Dr. Lisa Graham, and our phone volunteers, Paige Carlson, Josie Nisler, and Linda Liskowitz. And thanks to all of our doctors and phone volunteers who have been with us throughout the season of Doctors on Call. We hope you've enjoyed the program. Thank you for watching, and good night.